Hello,
Hi,
how you doing? I'm Tom, paramedic.
Chris.
How you doing?
Yeah, good, thank you.
Where are you today?
Just at work.
Okay.
I work for an independent ambulance company.
Okay, bro.
Where are you today, Tom?
I'm in Lancaster.
Oh, very nice.
Yeah. It's
At home?
I'm at home. Yes. So it's at home today. My daughter is in and out screaming in the background, so I may have to be tactful with the mute button as we go through it. Bedtime soon, anyway, so nap time should coincide when I'm speaking, hopefully. So yeah, the beauties of working at home.
I was admiring your map on the behind you, though. So.
Oh yes, I'm probably there. I think that's Cumbria. So one of our campuses about there. I should have a spot on. I should put a little arrow on it.
I like the idea of the Ambleside campus.
Oh, it's lovely. Yes, yeah, it's very good. We don't teach there, but we have our away days there. Yeah, it's a nice spot.
Away days, Matt?
I think we have our away days in another room in the building.
Yeah, different building.
Yeah.
If we're lucky, it's a different building.
All right. Well, hi, everyone. I think I've met all of you. So we're still waiting for a few people like Georgette and Ashok to come through. Just a quick thing, Antonia, this may not apply to you directly as much, but Tom, Chris, and Bill, you'll have about 15 minutes to talk. So we'll send you a direct message at about 14 minutes in, just saying that you have a minute left. And if you all go way over the time, then Ashok, who is still to come, someone will jump in and say, thank you.
If we go way under,
then it's brilliant.
Right,
we are more than happy. Then we will have a longer panel discussion.
I planned for about 10. I think 10 minutes is what I've planned for.
Perfect. Great. Yeah. So
I think mine will be nearer 20 than 10. We're here.
Okay.
Actually, 5 minutes of mine.
Yeah, I'm wondering if, having said you might change the slides for me, would it be feasible for me to do them myself? It would be quicker.
Yeah, that's fine.
Can we just experiment with getting the slides up?
Yeah, if you can share your screen.
Yep. And then you see, I'm getting desktop. I want the desktop.
Okay.
But it doesn't seem to open.
So once you click share screen, you have to click desktop, and then you have to click the blue share button that's at the bottom right.
It's gone to open system preferences, is that right?
Nope, no. All right, how about this? So Bill, I am going to share my screen, and I am then going to give you control. So what that means is that, and Chris, you have to click twice, right, with your mouse before you can control with your keyboard.
Yeah, I think that was right. You definitely at least have to click on it once.
All right.
So I now click twice.
No, just give me a second, Bill. I will. Yeah. So now if you click on the screen, there you go. Now you can control using your keyboard or the mouse, however you like.
That's super. Thank you very much, Mihir.
All right.
Yeah, I think. Oh no, it's not continuing.
Try again. Just click on this. So you might have clicked somewhere else. So just click on the screen again, and
that seems to be working fine.
Yep.
It won't go back, but I suppose that doesn't matter.
You only have one shot at this, Bill, now.
Yeah.
Is what it means.
So it looks as though I have to double click each time to move the slide, Mihir.
Okay. That probably means you might be clicking somewhere else, but I think for now, because we don't have time to test out anything else, that's what we have to go with.
Now it's not doing it at all.
Can you click on the screen? There you go.
Yep.
So it seems like if you click on the screen and try and click somewhere else.
Yeah, I think clicking on the screen seems to work. So shall I close this now?
Yeah. So I will start. I'll take the.
Yeah, you take it off because it's going to take me out of the meeting if I close it.
Yep. So
when you get to my bit, you'll
Yeah,
share your screen with me, and then I will start clicking.
Yes.
Perfect.
And
Okay.
Matt, are you okay if Bill's going at 20, around 20?
Yeah, that's not a problem. I'll absorb, because mine's asking seminar attendees about what they'd like to take back to their own practice. I can that becomes quite flexible to absorb any overruns by other people. I'll keep my eye on the 1338 timer.
Okay, great. And Matt, since we don't have Ashok yet here, would you be comfortable doing the transitions between Antonia and all of the speakers?
I can do, but it looks like Ashok's just arrived.
Oh, there. Okay, great.
Hi, just in time.
Yes.
Yep.
So
The supply
Ashok,
chain has worked.
yeah, Ashok, Matt and I were just discussing, are you comfortable doing a transition after Antonia shares her story to the next speaker? So it would be first Bill, then Chris, and then Tom.
Okay.
As you're the one.
Yeah, I just need the program in front of me in that case, which I'll, with the timelines.
Sorry, just to interrupt. Georgette's just messaged to say that her computer's having a couple of issues, so she'll join as soon as she can.
Okay. Matt, are you comfortable doing the introduction of the day then?
I've got my copy of the agenda, so I will
Great.
do the transitions.
Okay.
So we were gonna introduce everybody at the beginning, I think, just so that everybody knew who each head was if they pop up in the panel discussion.
Yeah.
But then as Antonia comes to an end, I will thank you, Antonia, and then I'll introduce the next speaker and what they're talking about. And that'll be grand. Yeah.
Are you going to introduce me to start with?
Yes, I can do that.
Okay, thank you.
All right. Perfect. Thank you, Matt. All right.
No worries.
This is a minute left. So this is when we are now going to go live, and I'm going to start letting the registrants in into the webinar. Is everyone good with that? If you're not talking, stay muted, video off, and for the panel discussions, video on, mic on.
Perfect.
All right. Thank you all.
So welcome to the next webinar in the series from the Collaborating Centre for Values-Based Practice in Health and Social Care. This one led by the Network for Paramedics, Stories and Sirens. I'm going to just wait a couple of minutes for other participants to join us. And then we'll start the webinar properly, as it were. So we'll just give a moment or so for others to join. Welcome all. I'm Ashok Handa. I'm the director of the Collaborating Centre for Values-Based Practice in Health and Social Care based at St Catherine's College in Oxford. And I'm delighted to welcome you to this webinar run by our colleagues in the network for paramedics. Really, we're so pleased that colleagues such as Matt and Georgette have joined the Collaborating Centre. They held about 18 months or so ago, or just shortly before the pandemic, a one-day webinar with the Education and Curriculum Committee from your National Society. And we were delighted that they decided to put values-based practice embedded within the curriculum. That's a major landmark decision. And of course, it fits in with the fact that paramedics literally are the front line of healthcare, and particularly for emergencies. And what happens by the roadside, in people's houses, out in the streets, the front line of paramedics is where really key emergency treatments and triage decisions are made for the patient pathway. And the very fact that they have embraced values-based practice in a model of shared decision-making is a really critical thing for the rest of the health and social care services to note. And so Bill Fulford, as the founding director of the centre, and I were incredibly pleased and impressed by the enthusiastic inclusion of this in the curriculum. So I want to hand you straight on to Matt. I think we've got an amazing lineup of speakers, and I'm really looking forward to the webinar. Thank you, Matt.
Thank you, Ashok. So just to give a brief overview of what's going to happen within the seminar, when we were planning this, we were aware that paramedics enjoy stories and enjoy storytelling, and it's a large part of our professional identity and the way that we learn. We have Antonia Cook, who is going to be introducing a story that's going to hopefully bring together the various aspects of the seminar. She's going to pass on to Professor Bill Fulford, who will give a good overview on values theory and values-based practice more generally. We're going to have some panel discussions. We're then going to move on to a little bit more story, followed by a presentation around some of the legal frameworks that sit behind practice, presented by Chris Jones. We then have a little bit more story, and then a presentation from Tom Davidson, who will be talking about opportunities and risks. At the bottom of your screens, you should be able to see a Q&A box, and you should also be able to see a chat box. We'll be keeping an eye on those, and if you do have any questions that you want to pose, please put those in the Q&A. If you have any observations, you can put those in the chat. We will be keeping an eye on both, so if you click the wrong one, don't really worry too much about that. With that, I'm going to hand over to Antonia, and she's going to begin the introduction of the story.
Thank you, Matt. So the case we're going to look at today is of a 90-year-old female who presented with new lethargy and left-sided chest and flank pain whilst at the podiatrist. The podiatrist dialed 999 and requested an ambulance attendance. The patient then described a multi-week history of left-sided axial rib and flank pain, a 48-hour history of worsening peripheral pitting edema in her legs, and positional shortness of breath. The past medical history included chronic kidney disease, stage 3, an in situ urinary catheter, a history of breast cancer with mastectomy, and osteoarthritis. Shortly after the ambulance crew's arrival, the patient's daughter requested to speak to the paramedic in a separate room. They informed the clinician that following admission to hospital 3 months earlier for pneumonia and hospital-acquired COVID-19, a relapse in the patient's breast cancer had been identified. This had been diagnosed as terminal with liver and bone metastases. The patient had been discharged from hospital 1 week prior. And the daughter states that the patient was unaware of the return of the cancer or of the terminal diagnosis, and they would prefer that it remain that way for the mother's mental health. They also confirmed that the palliative care services were not yet involved due to the short time frame since the diagnosis. However, the local hospice handover was reported as in progress. On examination, it was noted that the patient had upper lobe fremitus with good movement and depth. She was tachycardic and had a News 2 score of 2, but her seating posture was poor and she was unable to hold herself up in the seat, which was likely due to the spinal degeneration due to the cancer. And I'll pause there. Thank you, Bill.
Thank you for that, Antonia. And we're going to pass over now to Professor Bill Fulford, who's going to give an overview on values theory to try and put a little bit of flesh on those bones. Thank you.
Thank you very much, Matt and everyone. As Matt said, I'm going to talk about value theory. I'm just trying to make the screen work. Okay. What you'll see here is that I'm going to talk about value theory, but I'm going to talk specifically about philosophical value theory and values-based practice. There are, of course, lots of disciplines that work on values. And one of the things that's distinctive about values-based practice is that its origins are primarily in philosophy. And I'm going to look briefly at ordinary language philosophy, which is the specific area that has given rise to the work on values-based practice. I'm then going to show you how ordinary language philosophy supports the clinical skills training that is at the heart of values-based practice, and then a brief note on philosophical value theory, ordinary language philosophy, and the rest of values-based practice, and then I'll draw some brief conclusions. So ordinary language philosophy we owe to this man, J.L. Austin, who was White's Professor of Moral Philosophy in Oxford in the 1950s and 60s. What Austin drew attention to was that the way we use complex terms like values in ordinary, by which he meant everyday language, is a particularly powerful way of accessing meanings. Philosophers, as he pointed out, tend to reflect deeply on these concepts, and there's nothing wrong with that. But if we're going to reflect appropriately, we need to also look at how the concepts are actually used. So it's this focus on ordinary, non-philosophical language as a guide to meaning. And one of the best places, Austin himself pointed out, one of the best places to access ordinary language is through case studies. And of course, we've started with a case study this morning. So what do we get from this? Well, this approach expands our understanding. It doesn't give you a complete answer, but it gives us a more complete view. And of course, that means that we get through ordinary language philosophy a more complete view of the values involved in a given situation. And that's at the heart of values-based practice. So I think, Georgette, you've circulated a handout. If anybody hasn't got it, let us know and we can send this to you. And the handout gives more details of values-based practice. I'm not going through this in detail, but essentially values-based practice is like evidence-based practice. It doesn't give you answers, but it gives you a process that supports you in coming to answers, and specifically answers around balancing values in a given complex decision-making situation, such as the one we've heard about so far this morning. You've met Ashok already. As you can see, Ashok is a surgeon, and he's now director of the centre and has been key to the way the centre has developed over the last 5 years, where we've been moving very much from the kind of philosophical theory that I've been involved with right through to the heart of practice in surgery, the Nuffield Department of Surgical Sciences, with our colleagues now in the paramedic professions, and with others such as radiographers, OTs, and people working very much at the coalface of medicine. So it's an exciting area for philosophy to be playing out in. This is a little bit more detail of the process of values-based practice. As you can see right at the top, there are 4 areas of clinical skills. Again, this is all in the handout, which we'll be glad to send to you if you haven't had it already. So how does this ordinary language philosophy as the basis of values-based practice support clinical skills training? at the top there of the process. Well, the aim of all these elements of clinical skills training is to raise awareness of values. And as you can see, it's also about the surprising nature of value. There's lots of ways we do this. We haven't had time to do any of these exercises this morning, but you'll find them in all our published materials, the 3 words exercise, force choice exercise, and then close reading of texts, in particular as they come from clinical stories. And not just clinical stories, but everybody's stories. We've already seen with the case this morning that that Antonia presented to us that it wasn't just the patient's values that were in play, it was her family's values and of course the clinician's values, and we'll hear more about how that plays out as we go through the morning. I'm going to tell you a different story which illustrates the importance of what we frankly haven't been able to do today, which is to try these exercises for ourselves. This is called The Story of Dr. Zoe Barber's Surprise. This is Zoe and her partner, now husband, Tom. I should say that Tom and Zoe have published this story, so we're not revealing any secrets about their lives, but they have published this story, and it brilliantly illustrates the importance of the practice of values-based practice. So Tom and Zoe were both very high-powered young doctors when they got involved with values-based practice. Tom had been a prize-winning medical student at Oxford. Zoe has since gone on to get, I think, Ashok, it was the gold medal as the best candidate in last year's surgical exams. So both very bright people. And Zoe in particular had been very interested in values and ethics, and she'd read all the literature on values-based practice, but she'd never actually done this forced choice exercise for the first time. And the forced choice exercise involves choosing a minimum period of time that you would want, and that minimum period in the exercise reflects your values. So when we did the first surgical seminar, I got Tom and Zoe to sit in the circle with our colleagues and to do this exercise for themselves. And when we got to the point of choosing these values, I could see there was a bit of discussion going on between Tom and Zoe. And I went over and I said, "What's up with you two?" And Zoe said, "Well," she said, "Tom chose 6 months and I chose 25 years. And she was obviously very upset about it. And then she went on to explain that actually we're getting married in 6 months. And she, afterwards, when she wrote about this, she said, "As I said that, I realized that what mattered to Tom was finishing his PhD. That was his values. That was his top value. Whereas I'd been thinking about having a family." And she went on to explain, if I could have so misunderstood what mattered to the man I had known for 6 years, they'd gone through medical school and being young doctors together, and they were about to get married, what chance have I of guessing what matters to the patient that I met 5 minutes ago? So it was a light bulb moment for Zoe, that even though she'd read all the literature, she knew the significance of values and of the surprising nature of other people's values, for her to actually do this exercise with Tom and realize that although she'd known him for 6 years, she'd still misjudged what was going to be important to him in that decision-making situation. So we really need to train, we need the skills training to find out what matters to our patients and colleagues in decision-making situations. So that's the skills training that is at the heart of values-based practice. There's lots of other aspects of values-based practice where ordinary language philosophy is relevant. And again, I won't have time to go through these in detail, but it includes the model of service delivery, which is about multidisciplinary care and person-centered practice. It includes the 3 strong links between values-based practice and evidence-based practice. And it includes this model of dissensual partnership in decision-making. Dissensus is a bit like consensus, but it just means that nobody has to give in. We'll see how important this is in the case study as we work through it. So a final point is that ordinary language philosophy supports the premise of values-based practice. This isn't in the process, but it underpins the process. And the premise is that essentially everybody's values are important. So this is ordinary language philosophy. as it impacts on values-based practice. One of its other features that I personally find particularly attractive is that it's not an exclusive way of doing philosophy, but very much a partner to other methods. And we'll see how important that is later on when we see we'll be looking at law as it impacts on our case. And law is, of course, part of the values toolkit of healthcare, as is ethics, and values-based practice fits in with that. Some of you may have come across the decision aids that are being produced for some areas of decision-making. These are based on decision analysis, which is a sort of mathematical way of looking at values. Health economics is similar. And then there is a whole range of empirical methods that we get from psychology, anthropology, and other similar areas. So think of values-based practice as one of the tools that we need in our toolkit for working with values. And perhaps the most important of the other tools, interestingly, is evidence-based practice. And I've shown that diagrammatically here. You remember there are three strong links between values-based practice and evidence-based practice, and they are partners, particularly in this shared model of clinical decision-making, where clinician and client or patient come together and make a shared decision about the best way forward. Of course, we haven't time to go into that in detail today and all its complexities, but that's very much where the toolkit comes to absolutely the top of our priorities. That it's not that values somehow are against evidence. It's not that evidence has to be used or values have to be used only where we don't have evidence. They're very much full partners in shared clinical decision-making. The other area of partnership that ordinary language philosophy feeds into is other philosophies. This is one of our colleagues in the Collaborating Centre, Verdi van Staden, who is the Nelson Mandela Professor of Philosophy and Psychiatry at Pretoria Medical School in South Africa. And he's been developing a whole approach to values-based practice based on African philosophy, which he's calling Bathopili. Very powerful, and particularly in the kind of decision-making situation that we've talked about in our case study, where it's not one or two people involved, but a community of ideas from a family or from the health and care professionals. Another important area that some of you may have already touched on is phenomenology. Traditionally, phenomenology and analytic philosophy of the Anglo-American school have been opposed, but they are increasingly coming together in the 21st century, and this has been a powerful resource for values-based practice. Phenomenology understanding the life world of the person concerned, and I've illustrated here with the work of our colleague in Italy, Giovanni Stangolini, on eating disorders, and our colleague in Brazil, Guilherme Mezas, on addictive disorders and alcoholism. But analytic philosophy itself, which is the Oxford tradition, also has new resources for us. This is our colleague Anna Bergqvist, who works in Sweden and the UK, and she is the theory lead for values-based practice. And she's been working on analytic philosophy of values, and in particular, the way in which relationships underpin, personal relationships underpin the values that we adopt and develop. We've also got more theoretical areas. Two colleagues here, Colin King, working in critical race theory, and Colin has an important webinar coming up on 27th of October to tie in with Black History Month, and he's been doing some crucial work in the way that critical race theory feeds into values-based practice in the area of particularly mental health and race relations. And then Philip Corrales on the right here, who is, as you can see, the Fulford Clarendon Fellow at St. Catherine's College. He's been working on the very abstract area of semantic logic and how that feeds into decision-making. So some brief conclusions. We've looked at ordinary language philosophy and values-based practice. As this indicates, values-based practice is based directly on ordinary language philosophy, which employs our everyday, ordinary, or non-philosophical uses of language as a lens to reveal meaning. And the way that lens works is to expand our understanding. So the ordinary language philosophy helps us to see more of the values that are in play. That underpins the way ordinary language philosophy supports the clinical skills training at the heart of values-based practice. I've mentioned the 3 words exercise, which is directly aimed at helping us to see more values. The forced choice exercise, where we see the link between values and evidence. And from the story of Dr. Zoe's surprise, you see how important exercises of this kind are, even to those who've been through all the theory. So we haven't had time to do that in our 2-hour seminar, but this is why, as Ashok said earlier, it's so important that this work is in the paramedic curriculum. It's all about training, practicing it, doing it for yourself. I then ran briefly through how ordinary language philosophy supports the rest of values-based practice, right through from its premise to the core concept of dissensus in decision-making, and the way in which ordinary language philosophy encourages partnerships with other areas of expertise. I mentioned in particular evidence-based practice and how that fits in with the values toolkit and the range of empirical methods that we can bring to bear alongside the philosophical value theory. And there are, of course, these other philosophies. I touched on African philosophy, phenomenology, critical race theory, and semantic logic, and not last but not least, other areas of analytic moral philosophy. So it's quite an agenda. And I want to finish with this image of some of the people that I've shown you today. There's 1 or 2 on here that I haven't managed to touch on this morning. But what you see is that this is the next generation of values-based practice. My apologies, there's none of our colleagues from the paramedic field on this slide. It was made for me by someone else and I wasn't able to adapt it, lacking the relevant technical skills. But what's so exciting about the whole field is that it's the next generation that's really carrying things forward. The next generation of very bright younger people from very diverse backgrounds. And you know the famous byline for the Star Trek series, to boldly go where no one has gone before. And it's the next generation that I believe has to boldly go, exploring the philosophical and other areas of theory that will support the effective development of values-based practice. Thank you very much.
Well, Bill, thank you for that masterclass and some embarrassing photos of me. But that I think really sets the scene. I'm going to hand back to Matt, and we'll have the panel discussion now. So over to you, Matt.
Okay, thank you, Ashok. As you say, a very interesting presentation there from Bill. I've just been quickly reflecting on it as we go on, and I like the idea of having more tools in the toolkit as a paramedic. The next section, we're just going to open to some panel discussion from the other representatives here, but also just to remind everybody that the question and answer and chat boxes are available, and I'm keen to feed in questions that are coming from attendees as well as panel members having a bit of discussion. But I'm going to hand over to the panel now. So I'm just interested to see if anybody has any particular views, any reflections, thinking about Antonia's story and how values-based practice might start to play a role in that story. I notice most of my panel are still on mute.
I think something that really strikes me is like the patient's values versus our values. Antonia outlined a little bit about where she was in that section of her story and that initial bit of the patient, but then also the family's values. So where, at what point, like who has, I don't know, value authority, I think is something that we could talk about.
Yeah, certainly, you know, this is a really important point, Georgette, which is that the first thing for everyone is to be aware that values are in play. And being values aware is the first step of that process of values-based practice. And as you very rightly point out, whose values? Because there'll be your professional values, your personal values, there'll be the patient's values, there'll be their family's values, and how those interact. And if you, for want of a better word, where the hierarchy is really a key part of that discussion. And that's really with professionalism comes in. But I think it's a really important point you made about being values aware and the fact that they're all at play.
Could I just add to that? I think one of the things that, if we were doing this as an exercise, one of the things that we'd be looking for is for people to recognize that there is an assumption about the patient's values. And it's not an unfounded assumption. It may well be that the family are quite right that she doesn't want to engage with the possibility that she may have a relapse of her cancer. But that assumption hasn't been unpacked. Nobody's talked what really matters to that patient. Of course, we have more story to come, but I guess we're all often in that situation where there's an assumption what's important to the patient, but we haven't actually found out. And it can be incredibly hard and difficult to know how to find out in the sort of situation that's been described. But at the very least, we need to be aware that the assumption that the patient doesn't want to know or doesn't want to engage with the possibility that she may have a relapse of her cancer, that assumption may be wrong.
I'm going to put a question to the panel members, but also to attendees that they can type up in the chat. I'm going to ask people how they might try and open that conversation with the family to try and discover what values are at play, and whether you have any ideas of how that conversation might be started. Obviously, we've got the panelists that we can see. If people want to type into the chat boxes or into the question and answer, then I'll try and feed those into the discussion as well. So has anybody got any ideas about how you might start that conversation with this family to try and discover what values are at play?
I think just while people are thinking, I think a really simple thing would be to ask, but it's actually so much harder to just ask sometimes, isn't it? And ask in the right way and in a way that's understood. And Chris, I think you were going to say something as well.
Yeah, I was going to touch on this in my part of the presentation, but just while we're thinking about it, one of my relatives had a diagnosis of motor neuron disease, and the kind of been through this, and when they were approached by the neurosurgeon about the diagnosis, the question was put to him, what do you want to know, and do you want me to discuss with you or your family? And I think if we can gauge what level of knowledge the patient wants, we can still respect their autonomy, because they can make an autonomous decision not to know if they want to do that. So that would be one of my ideas, how we approach that.
I think that's important. We've had Joe Thomas in the chat has agreed with the idea of just ask, but I do feel that sort of then begs the question of how do you ask? Because to just turn around to the family and say, what are your values in this? They may miss the point of the question, and it links quite nicely to the idea of ordinary language philosophy. Are we using high level concepts, but we need to make them accessible to our patients? Jo has said that she comes from a different professional background. Sorry, my chat box is moving up and down here. Comes from a different professional background. I'll just hand to Bill. Bill, you were going to say something.
No, I was just apologizing. I think it's because I'm looking at the chat box. It may be interfering with your viewing of it. So I've stopped.
Oh no, that's fine. No, Joe says that they're more confident with the idea of values-based practice, it having been in their curriculum. Ashok's talked about how it can be difficult to start a conversation. Often start with what they think is the matter and what would be a good outcome for them, and that can lead into values, this idea of what someone values as being a good outcome. Georgette?
And I noticed as well, and that ties in really well with what Veryan says in terms of operating on assumptions. So I think there is quite a tendency sometimes to assume that we know the patient's values, perhaps because we look like them, or we work in a similar area, or we've got a similar background, or something like that. And so we often finish their story for them. So that operation on assumptions, if we don't do what Joe outlined, and which is just to ask.
Very good.
I think one area that probably underpins value-based practice from what I've been reading around and using is the understanding of the mutual respect of differencing values within the situation, actually exploring all the values that are present. And I think Bill mentioned that one potential value set that hasn't been explored is the patient's value and how they see the situation. So I think it's coming into the situation and realizing that's something you can use within your clinical diagnosis, and often particularly maybe coming from a quasi-medical profession coming into it, you think quite clinically when you approach patient sets, and you think of observations, and you think of destinations, and you think of outcomes, and actually stepping it back and engaging with them on their values and exploring them deeper will allow you to come up with a more holistic assessment of the patient, rather than just going in and thinking what's clinically wrong with this patient and how can we get them clinically better. So actually starting the situation, there is more to a patient engagement than just observations, and how they appear is probably a best way to approach as well.
Sorry, just to feed in, John has made a link between Bill's story of the different values between 6 months and 25 years. And when someone doesn't know for sure the values of their partner, to assume that the family know the values of the parent is an assumption. And also to think about the fact that these values might change and evolve as the patient moves through, and their health and their well-being and their situations change. And I think that's certainly true, that whilst the family may feel they knew what the parents' values were, are they sure that those are the same values now? Time is marching on, so I'm actually going to hand back to Antonia now and ask her to continue with her story and introduce a little bit more detail. And after that, we'll be moving over to Chris, who will be talking a little bit about the legal framework. Feel free to keep putting questions into the chat and into the Q&A. Some of them we'll try and answer by text. Some of them we'll bring into the later conversations. So back over to you, Antonia.
Thank you. And the whole conversation has nicely led into this evolving story. So following on with our 90-year-old female, and still in the room, the paramedic is still in the room with the daughters. The family then stated that the hospital team, during attendance and also discharge, had not informed the patient of her diagnosis. And in discussion with the family, as they felt it would be bad for the patient's mental health and a potential relapse of her delirium and confusion, which had been affected during the hospital admission. The paramedic discussed with the daughter that they advised the patient to attend hospital for further investigation, and that was due to the potential causes of pulmonary embolism, heart failure, pneumonia, and untreated cancer-related symptoms. The family then highlighted that the patient's unwillingness and likely refusal to return to hospital. They again asked that the patient not be informed about her cancer, and asked if the crew could omit or white lie about the cause of the pain and recent decline. The patient did not have a lasting power of attorney for health and welfare in place, or an advanced care plan, and was assessed as having mental capacity at the point of the attendance. The clinician highlighted to the family the ethical, moral, and legal concerns they had with withholding information from the patient, and the ability for the patient to make an informed decision about her own care without all of the information pertaining to herself. The paramedic also felt that it was not their place to break this challenging and emotionally fraught news, as they did not have all of the information surrounding the diagnosis or many of the answers to questions which would likely arise. And then over to Chris. I'll pause there.
Thank you for that, Antonia. It leads in nicely to discussion of the legal framework behind this. So our paramedic has highlighted to the family that there are some concerns, ethical, moral, but also legal, which quite often we get concerned about. I'll pass over to Chris, a former colleague of mine and Master of Medical Law, and I'll let him start his presentation. Thank you, Chris.
Hi, Matt. Thanks very much. Hi, everyone. So I'm just a paramedic, same as everybody else. I'll start with that. And so I went to study medical law so that we could analyze these questions as paramedics and try and put the law into an accessible and paramedic understood way. So hopefully that's what I'm going to try and do and make it short. So I'm trying to just get these slides to work. 2 seconds. There we go. So the first thing I plucked out, and we've already had a big discussion about that, the only reference in the narrative that I could find was about the patient's wishes, really, was that she didn't want to attend hospital again. However, there were some of the daughter's wishes there about not informing the patient of a terminal illness and due to a potential deterioration of mental health and a relapse of a delirium or confusion. And this was well-meaning. They wanted to protect her mother, and the daughter had said to the paramedic that she wanted to spend the remaining time left with her together, probably not upset or in any kind of treating her as a terminally ill person or a mother changing her attitudes towards her and things like that. So to run over the legal framework, the Mental Capacity Act certainly comes into play here, and we heard that the paramedic on scene assessed that the patient had mental capacity, and that plays an important part, because now we've got to decide, if she's got mental capacity, how can we make any decisions for this patient with proper consent? Because if, even though she wants to not go to hospital, she's making that decision based on an absence of a large amount of information, i.e. a terminal illness diagnosis. So any actions that I see performed by health professionals in this case could be argued as non-consensual and unethical, because the patient doesn't know the reason behind the decisions that she is being asked to make or not make. And then I'm going to look at some of the cases that have been raised, that have raised these issues. So you might be familiar, if anybody's done advanced life support or any resuscitation updates in the last few years, the case of Tracy in Cambridge hospitals, which is underpinned do not resuscitation training, DNA CPR orders, resuscitation training since 2014. And is, if anybody's heard about this case, this lady was terminally ill with lung cancer and had a road accident. And unfortunately, she was driving a car. She was fairly fit, even though she was ill, and was driving a car and was involved in a road accident, was rendered quadriplegic. And what happened in hospital was this lady was subjected to a do not resuscitate order without her consent and without discussion or involvement in her care. Now, it came very clear during this case and during the court case that this patient wanted to be involved in her care. She was approaching medical staff who were treating her, about asking her about her health, about the state of her health. The family only found out that there was a do not resuscitate order on her when they had a look at her notes, and it came as a big shock, and nobody had been involved in a discussion with that patient. So the judge, or one of the judges in the case, Lord Justice Ryder, he actually said that the duty to consult the patient is integral to the procedural obligation to ensure effective respect for the Article 8 rights. So what does that mean? Well, that means that consulting the patient, or not consulting the patient, engages their Article 8 rights to a private life under the European Convention on Human Rights. So by not involving the patient, we're potentially overriding the rights, this person's fundamental human rights. That interest is the autonomy, integrity, dignity, and quality of life of the patient. So to come up with a decision not to discuss with the patient, and this is not a criticism of the paramedic, this is a criticism of how this case arose in the first place, is that potentially by not telling this patient or giving her the information, we've overridden her dignity. We've not given due respect to her autonomy, and it could potentially affect the quality of life of her care, because if she doesn't know she's terminally ill, how is she going to access the relevant medical care and treatment? As it says, that process is individual to each patient, albeit informed by good clinical practice. So, as we mentioned in the group discussion earlier, although autonomy is key to that decision making, she could make the autonomous decision not to want to know what is wrong with her. But unless somebody asks her, how do we know what her values are and what her basis is for making that decision? So I think, although the case of Tracy is about do not resuscitate orders, I think the comments there make a very powerful statement about how integral that discussion and our duty to consult is with our patients. A recent case from the Supreme Court, Montgomery, this was about consent. And in this case, it was a maternity case, and this is about giving information and what level of information is required to give to the patient. And here, there was a very powerful statement by the Supreme Court that the doctor is under a duty to take reasonable care to ensure that the patient is aware of any material risks involved in any recommended treatment and of any reasonable alternative. So I think we've got to ask ourselves, in the case that we're discussing, was how can the lady be made aware of any recommended treatment if she doesn't know what she's being treated for? So, in my opinion, it's a wholly unlawful and unethical way of treating the patient. The doctor, however, is entitled to withhold from the patient any information as to risk if he reasonably considers that its disclosure would be seriously detrimental to the patient's health. So I think here, in our case, the paramedics acted in a really good and effective way. We haven't heard the whole story from Antonia, but the paramedic will go on to discuss, and multidisciplinary teams will be involved. And I think that's a really important way that the paramedic dealt with this case, because I don't think the paramedic dealing with this lady would be in a position to know if she gave that information to the patient, whether that the risks recommended by the daughter, so a risk that it will be detrimental to my mother's health, it will be it could lead to a deterioration in her mental state and things like that. The paramedic in this case wasn't in a position to know the full medical history of the patient, and whether that, if she did disclose that terminal illness disclosure, whether there could be a reasonable detrimental to to the patient. However, going back to the case of Tracy, in that case, they absolutely determined that just upsetting the patient is not seriously detrimental. We can't just withhold information if we believe it's going to cause upset. It's got to be a serious deterioration in that patient's health. And that's a key point in that case. One of the first cases that really sparked my interest in medical law was Miss B in a hospital trust. And I think Baroness Sloss, then Dame Sloss, who was president of the family court, she made some very powerful statements in this case, which was a lady who had been rendered quadriplegic by a brain hemorrhage and was unable to breathe for herself. And she wanted to be removed from the ventilator and be allowed to die peacefully rather than be kept alive. And in this case, the judge agreed that it was her decision and it's her autonomous decision, and described what she called a benevolent paternalism, which I think the daughter here was engaging in her parents. The daughter had took on a parental role over her mother, and albeit a well-meaning paternalism, but she'd taken over this parental role and decided that she didn't want to hurt her mum by giving her this information. And I think this is a case where this benevolent paternalism was definitely demonstrated, and how we get over that. I think we can have ethical discussions about whether families are allowed to take a more paternalistic role over their relatives. At the end of the day, we all accommodate what our relatives want. We all make sacrifices to our relatives. So there could be ethical discussion about whether actually it is ethical to take a more paternalistic role over members of our family than, say, a doctor taking a paternalistic or a paramedic taking a paternalistic role over a patient who they say, I know better than you. And sometimes families do, and they do make accommodations. However, the law views the patient's autonomy above everything. It's although the courts respect the sanctity of life, they don't see keeping people alive at all costs above that patient's autonomy. So in this case, the court found in favour of the claimant, and she was allowed to be removed from the ventilator, and said that she'd been treated unlawfully for 18 months. So I think that just goes to show how. Sorry, I don't know what's happened there. I think that just goes to show how much courts view autonomy over and above other ethical and relative discussions about how we treat our patients. I think that's. I've lost my slides there, Matt. I think that's the end.
Thank you very much for that, Chris. There's certainly some very interesting content in there. Whenever we get into these sort of discussions, and it's one of the interest, partly an interest of making sure that we consider values and values-based practice, but also one of the reasons why, when planning this, we decided to structure any discussion around an actual story. There's that tension between the law in quite a dry academic way and practice as it happens in the real world. It's nice to hear that there are considerations. I think it always feels good as a paramedic to feel that the law accepts that even if you make decisions that in the end are considered to be wrong, they can be made for the best of reasons, and that you're not doing them in a criminally negligent way. And I'm not using the word negligent necessarily in a legal sense. I'm just using it for ease of understanding. I think one of the things that you mentioned, and I'm going to use it as a kicking off point for the panel discussion, this idea of the patient can exercise their autonomy by deciding not to know about their condition, raises a really interesting question to me, and I made a note of it as you were talking. How do you start a conversation of what do you not want to know by exploring that?
I think for me, a lot of patients know deep down that there's something seriously wrong on a lot of occasions, and I think they just don't want to hear the bad news. And you know, I think it's perfectly reasonable for somebody to say, no, just discuss it with my wife, and I'll just go away, and you know, they can do what they want. You're right. It puts people in a very difficult position, because how can you treat somebody without the potential of slipping the diagnosis into a discussion and informing them? But I think that's a risk that you know that they would have to take. I think from autonomy's a difficult one if you're devolving it. And again, Antonia mentioned that there was no sort of lasting power of attorney over health or welfare. I think that's a really important thing as well, that wouldn't have been possible because the patient had capacity. So this person still has the absolute right to make whatever decision she wants. And I think that's got to be put first. And the fact that there's only one mention, there's only one mention about the patient's wishes is something that Bill, you know, mentioned straight on in his presentation. You know, actually, although we're trying to make patient-centered decisions, which is what the paramedic was trying to do, and the paramedic was trying in an impossible position by the relatives, the patient wasn't at the center of this daughter's decision making. Her own feelings were at the center of her decision making. She didn't want her to upset her mum. She wanted to spend more time with her mum. However, all the legal cases show is that withholding information from the patient is unlawful, and there's no getting around that. The courts put the patient's autonomy right at the forefront of everything in medical practice. I don't know if people agree or disagree with that.
Well, could I venture on that one?
Yeah,
because you mentioned Montgomery.
Yeah,
and I don't know what I'm thinking of is the minority concurring judgment from Baroness Hale, who went on, of course, to become president of the Supreme Court, and was the only woman actually on the panel of judges for that caesarean section case. And Baroness Hale spells out in her minority judgment that this is about understanding and working with the patient's values, with what is important or matters to the patient. And this is why I think I would, and Matt, I'm venturing this from a position of blissful ignorance as to the law. Putting all your money on autonomy is not my reading of Montgomery. It's saying, of course, autonomy is important, but it's only one value that may or may not be important or matter to the patient concerned, and that it's our role as clinicians to enter into, and they use the phrase dialogue, the term dialogue, they use the term conversation. It's a two-way process. And then to find out what matters. So what I suspect, where I suspect we might agree, Matt, is we don't want people to take away from this that you have to go in brutally and just saying, look, you know, you've got cancer, and then I've covered off my legal back by telling people there. It's not that at all. It is about entering into a dialogue. I think the other thing that I'd like to throw in, again, vicariously, because I'm picking this up from Ashok and the way he and Zoe and people work, is that it's not always one particular person or one particular team member that is where this will come down to. But we found in an early surgical seminar that the radiographers were saying, well, actually, we often, when a patient's seen the surgeon and then they come through for X-ray, and we're doing a practical procedure with the patient, and at that stage, the patient's much more able to start talking about what matters to them. And if we're open to that, and if the surgeon is open, and if the patient agrees, we can discuss it with the team as a whole. If they're open to all that, that means that the teamwork then becomes really important to that dialogue with the patient, from which emerges what matters to the patient and the extent of the information that they really want to have. Of course, for some people, they do want all the information. And I think we've all had experience of that difficulty of sometimes knowing how much the patient really wants to know. But there is a dialogic process that's written into the Montgomery ruling, and it is about finding out what matters to the patient. I think, Matt, just going to risk one more point. You mentioned the medical opt-out where there's serious harm. The Montgomery ruling, like the case you mentioned, spells out that this is a very, very limited exception. And it's got to be major and significant harm. It's not just, well, it's going to upset the patient a bit if we talk to them about it. That's not where the opt-out is meant to operate. And they said it should be used rarely, if ever, was, I think, the phrase in the Montgomery ruling. So
absolutely,
we can't avoid it. But what I think is so positive about the Montgomery ruling is this emphasis on dialogue. And implicit in the ruling, although not, I think, explicit, is that the dialogue isn't necessarily between one team member and the patient or client, but it can be a team process, and that's where team working can be so important.
I think that's so important, and I probably didn't clarify that because it was kind of jumping towards the end of the narrative, and certainly the paramedic in this case convened a multidisciplinary team meeting. That's how he or she approached it. And I thought that was an excellent way of dealing with that situation, to find out actually who has this patient's medical history, who, what level of dialogue does she need? What are her best interests? However, looking at best interests, we can't serve those best interests if the patient has capacity. We can't act in her best interest because we need to find out what they are from her rather than act in her best interests for her if she's got the capacity to make that decision.
Yeah, I think
there's some
material risks and benefits, isn't it? What's material and what is material is primarily what matters or is important, primarily, but not only what matters or is important to the patient concerned.
Yeah,
I'm going to briefly interject here because I think that it would be useful if we moved on to the next part of the story. But just to quickly sort of summarize what I think is coming out of some of the discussion that Bill and Chris have been having there, and thinking for those of you that are operational paramedics and wondering how this might apply, is recognizing that not everything is time critical. Often we talk about our practice in very quick decision making, and we pride ourselves on that. But a discussion can be quite a long form process. The decision might be that this patient does need to be established what their values are and what information they do or don't want to receive. But that doesn't necessarily have to be achieved in the next 2 minutes in the optometrists when you've been called there. Before we move on to the next part of the story, however, because the balance between panelists and attendees is quite fine, we're going to have a sort of 10-second or so brief interlude as we turn all of you who are attendees into the same access as panelists, so that when we come to the discussions as we go forward, you can actually be seen and you can be heard as well. If you're not happy being seen, don't turn on your cameras, don't turn on your microphones. Obviously, the seminar is recorded. You're more than welcome to put your questions in the Q&A boxes in the chat. But if people want to actually just speak up, as you may do in a face-to-face seminar where you put your hand up or stand up if you want to make a point, then please do, and we can bring you in onto the seminar. But what I'm going to do now is I'm going to hand back over to Antonia, and she's going to give us the conclusion of her story. So, sorry, 10 seconds, and then Antonia can give us the rest of her story. I'm watching my little box fill up with panelists rather than attendees now. One more to go. I must thank at this point Mihir, who's our technical expert, who's in the background, who's doing an excellent job organising all of this. It looks like there might be a slight problem moving Varian into the panelists. It does seem to move very quickly. So I'll hand over to you, Antonia, and hopefully nobody will miss too much as you move forward. So the rest of your story, thank you very much.
Absolutely. So now to just really put the meat on the bones about the decisions that were made and why they were made. So the paramedic worked in conjunction with the family to ensure that they understood the need for the patient to be informed and be involved in the discussion. And following this, the paramedic contacted the patient's GP to inform them of the situation. And it was discovered that the GP was not yet aware of the new diagnosis, as the discharge letter hadn't reached her, but she did understand the complexity of the situation and the need for the patient to be involved. The GP also agreed that the paramedic was not the best placed person to break the news, and that the conversation required a multidisciplinary approach and planning. And to add to the challenge of the whole situation, it was also at the end of the working day, and the GP did not have the information to be able to plan for this conversation immediately to hand. The GP was, however, due to attend a multidisciplinary team meeting with the local hospice in the morning and agreed to raise the patient for discussion. The paramedic agreed to contact the hospice to inform them of the situation so they could prepare from their end and gather information for the meeting, as allegedly, as we've discovered already, the patient was in handover from the hospital to the hospice. The GP advised that if the patient did not wish to attend hospital for the day's presentation, then community bloods and diagnostic tools were likely to be inconclusive or display unreliable results, and that was due to the complexities of the cancer. So the local hospice nurse was in agreement with the GP, and they agreed that the patient required an urgent discussion to break the news, or at least to be involved in the discussion, but that the paramedic, again, was not the best placed person to do that. The patient was added to their list to be discussed at the MDT meeting the next day, and the nurse also provided a number for any future ambulance crews to contact if they attended prior to the palliative care plan being in place. And this to be really clear with both the family and on the patient record, that it was to be utilised prior to any transportation to a care facility. The patient was informed of the potential non-cancer causes of the day's presentation, and then that led on to a holistic conversation and the care journey options for them. The patient then once again demonstrated full capacity, and that the patient valued remaining at home with her daughters and receiving any treatment at home. She did not want to attend hospital, but wished to be comfortable at home, and that was stated quite clearly. And the paramedic raised the idea of a lasting power of attorney and advanced care plan with the patient for them to just consider moving forwards, so that they can explore, understand, and record their wishes while she's still able to do so. The daughter had concern over the ability to then safely transport the patient home in their small car, and particularly with the day's presentation and the spinal degeneration. And the ambulance crew facilitated transport to the patient's home and ensured that the patient was left in a comfortable state in her own home, with a robust worsening advice and plan in place to move the challenging situation forward. And that's the conclusion.
Thank you for that, Antonia. So we're going to move on now to Tom Davidson, who's going to consider some of the ideas of opportunities and risks that occur during values-based practice, and with reference to the story that we've been listening to. So over to you, Tom.
Thank you, and I'll just get my screen share up. Swap it over. Are people able to see that? Just checking.
Yes, we're able to see that, Tom.
Brilliant, thank you. So I was asked to look at the opportunities and risks today and exploring around applying values-based practice within this scenario and more broadly. Just my own background is I'm a paramedic, but also work in academic settings, and what I try and do is understand how theory applies to practice, and my own use of values-based practices, I'm probably emergent in my understanding of it, and trying to get a bit of a better understanding of how to apply it to practice. But from the reading and from engaging with it so far, it seems to be a really good model to be able to apply some broadly conceptual theories like values into everyday practice. And I think that the ordinary language theory is really interesting in terms of how you take these concepts that maybe appear to be quite abstract and bring them into reality in terms of your day-to-day practices. So what I'm going to do today is hopefully discuss that probably in the general terms, and then we can use the discussion afterwards to talk through what the risks and values are. What I find really interesting about value-based practice and one of the real opportunities of it is it's a way to actually ensure that you have inclusive practice. One of the opportunities you have, because at the very heart of it, it's about mutual respect of difference in values. So there were clearly in this scenario some difference in values between the individual practitioner about how they felt the outcome of the treatment, the carer and the family member about what they wanted, and the potential values of the individual patient. That there are lots of values at play here, and the whole process allows for that mutual respect, and that immediately removes discrimination and racism and any areas that are fundamental to a difference in values, which is a really great position to hold. And often it can be quite hard how to actually inclusively practice, and value-based practice is a real good way of doing that. It focuses on a process rather than outcome. Often, and I'll talk about in the risk later, but often when we treat patients, if we go in with a predisposed outcome, we know this patient is terminally ill, they need to go to hospital because there are some red flags. That can be quite challenging in terms of getting a patient-centered care. And actually focusing on the process of engaging on a value-based approach and actually engaging with the individual patients is really important, because then you come up with a truly balanced, we talked about this earlier, and Bill talked about having balanced decisions. And ultimately, it allows you to have empathetic interactions. It allows you to have interactions with individuals that are based on their needs, and that's individuals within the whole spectrum of the assessment. So that could be relatives, that could be patients, and that could be yourself. But it allows you to interact on a more meaningful basis. That there was sessions earlier talked about phenomenology as well, and that actually is about exploring the meanings of situations and exploring how people view and interact within given situations. So putting values at the center of decision making really encourages that approach and allows you to have the opportunity to have patient-centered care. So patient-centered care is a really important aspect of modern healthcare. It's a really important emphasis of how we ensure that we are delivering care to the patient. It should be every outcome. As an educationalist, as a paramedic, ultimately I want to improve patient care, and this is one way of developing it. I think Bill mentioned earlier that they are links in terms of evidence-based practice and values-based practice. From looking at some of the literature, often the criticism of evidence-based practice is either it doesn't use values at all and focuses, if you think about the definitions of evidence practice, where you've got the evidence, patient expertise, practitioner expertise, and patient values. Sometimes that patient values doesn't get included in the decision-making process. Or It doesn't understand the broad nature of values that values-based practice does, and values are everywhere, and they are more than just one set of patient values. So it allows you to engage in decision-making that is based on a multitude of values when we go forwards. It also allows you to explore patient interactions deeper. I think I mentioned in one of my comments earlier that there's a big risk within patient care that we only interact on a clinical level, that we only interact on the patient's observations and how they explore with us. But using this approach allows us to get meaningful interactions with patients, which is quite hard to teach. It's quite hard to teach undergraduates, and actually using value-based practice allows you to teach a method of engaging with individuals based on their core value set. And if we can engage on that level, it means that any decisions that are created from that are balanced across the patient care spectrum. So the literature and Bill mentioned earlier about ensuring that balanced decisions are made. So decisions are made that are balanced between the best available evidence, between the expert opinion, and between the patient and relatives. And when we come up with an outcome, particularly that Antonia mentioned there, that actually the outcome that was created was balanced in relation to the risk and in relation to the patient's healthcare. I think was mentioned earlier about paramedics. We probably have a predisposition to doing everything quickly and coming up with an outcome very quickly. And often there needs to be a deliberate approach to using values that may take a bit more time, that we're not used to in our skill set, and ensuring that we engage early in terms of values and use that as an approach to engage with patients. It is really important. I think talking about some of the risks, a lot of the literature suggests that often the obvious value clashes are noticed. So you might use an example of when we're looking at patients because they're religious reasons that don't wish to take blood products, and the practitioners viewing, if they have a hypovolemic injury, that is the appropriate outcome to give. There is a clear values clash there between the individual's religious values and the practitioner's healthcare values and how they want to proceed. And often they're quite obvious and can be seen. But what is hard to notice is the subtle values that are at play in this situation. And without the dialogic engagement with patients and relatives, you can't explore those values any further. And if you go into a situation not understanding that there needs to be a mutual respect of values, it will force you to go through a route where you only notice the big values clashes, and actually you're not exploring the individual's ethical, religious, cultural values, and actually you're not exploring your own personal values. What I've alluded to earlier as well is about there is a big risk that in healthcare we purely focus on clinical interactions. We purely focus with how we engage people on an observational level, and what I mean by that is their heart rate, their blood pressure, their SATs. And increasingly now, paramedics are probably moved from a position where we were quite transactional in our care, where we used to treat patients based on their clinical output. We were trained heavily on cardiac arrest, medical emergencies. But what you see now, and is a great example of this scenario, we are entering into very complex patient engagements that move beyond just clinical interventions that will resolve the care, and they move into a situation where we need to understand the holistic nature of patients. Now that phrase holistic nature of patients can be quite ambiguous and can be quite broad, especially to undergraduate individuals that come through learning pathways. And actually one benefit of using value-based practice is it allows you to put a framework on giving equal measure to values, as well as clinical judgment and as well as expert opinion. What it also does is it allows you to not only to one of the risks is not applying your own values, and be that personal or professional. We as paramedics have collective professional values, so we have our codes of conduct. When I work with undergraduates and some postgraduates, They will understand the HCPC code of conduct while they're going through their training, and actually they'll use it quite judiciously in assignments and use it to underpin their education. But when you get into practice, they're often a piece of paper that you don't immediately use within your own practice sense. What value-based judgment can do is allow you to incorporate those value sets into decision making and incorporate your own personal value sets. We are not automatons. We're not individuals that come to a situation with no understanding. So we need to bring ourselves to that situation to be able to know what are our value sets and how does that interact with the individual situation. My own personal approach is that I think this is a real great way you can apply theory to practice, and you can start really great that we've got it now in the curriculum and we can teach it to individuals, particular undergraduates that often find these concepts quite challenging to integrate. This gives us a framework to be able to teach individuals on how you can develop your approach and how you can ensure that you are making a balanced decision that is aware of mutual respect of difference values. And the ambulance service in particular has challenges with equality and diversity, in particular in relation to treatment of staff and patients. We are not performing very well in terms of that. So I think one really good way to ensure when we deliver care that it is appropriate for an individual is focusing on the values, having that dialogue with patients and having that communication with patients about how they feel in any situation and what their values are will mean that your treatment or your decisions or behaviors are then grounded in a really balanced approach when you're moving forwards. I've just got into understanding value-based practice and really interested in it and potentially use it in future research. And I think it's a really great way that we can tackle approaches, and hopefully this discussion and now we can look at some of the risks in relation to this patient that Antonio's gone through. Thank you.
Thank you for that, Tom. So again, some interesting ideas in there, some nice links back to what Bill introduced